I'm going to hand over now to Aideen Maguire, who was having some technical issues when I introduced her. So straight over to you, Aideen.
Yeah, guys, thanks for bearing with me. Hopefully you can see my screen now. If you can't, just let me know. I'm going to jump straight in. So as Anne said, I'm Aideen Maguire. I'm going to be talking to you today about a small section of a programme of work that I'm working on looking at mortality risk amongst care leavers. And really it's as part of a larger programme of work which explores mental health and mortality amongst children known to social services, children in care, and what happens longitudinally after they leave the care of social services. So just to set it in a bit of context, Northern Ireland at the minute has the highest rate of children in care at any one time than it has in the rest of history. The number of children in care is increasing in Northern Ireland, and this story is the same across the UK. Now, we know that these children have not only increased mental health needs, but we're beginning to see that they have a higher mortality risk after leaving care. And these figures aren't new. For anybody who works in this area is well aware that children with a care history have a higher mortality rate. But what's unknown is what are the biggest risk factors within this group and how do we prevent and change these numbers. I have worked with our project partners in the Department of Health in Northern Ireland and Barnardo's. They have been highlighting the need for sort of strong empirical evidence to support this sort of anecdotal, smaller research studies that have already been done. I mean, some of these information is based on freedom of information requests, which lets you know about sort of mortality rate in care, but there's been very few large-scale empirical studies done, especially at a population level. So after speaking with our project partners, we were trying to understand what's needed, and what's needed is this strong empirical evidence at an individual level. There's a need to compare like with like. If we're comparing children with a care history, is the correct comparison group the general population? And there's a need to better understand who's at most at risk. So that's what I aim to do using this administrative data linkage study project. Northern Ireland is unique in that it has an integrated health and social care system, which means that we centrally hold our social services data for the entire Northern Ireland population. The data dates back to 1985. It contains health and care number, which means that it's easily linked to other health data sets. So for this particular project, we linked social services data from 1985 to 2015 to primary care data, mortality records, prescription medication data, and hospital data, which included self-harm presentations and psychiatric hospital admissions. And the aim was to create the UK's first population-wide longitudinal study of both the long-term mental health and mortality outcomes of children known to social services. And today I'm going to talk very quickly about just sort of these top three right data sets, where it's the social services data linked to primary care and mortality records. So the social services data spans from 85 to 2015, but when looking at the data in more detail, these first 10 years of data aren't the best quality. There's an awful lot of missing data, a lot of missing health and care numbers, and we all know the flaws of working with administrative data. So for this particular cohort, we just took a sample of everyone born or resident in Northern Ireland between 1995 and 2003 and followed them up over time, and this allowed us to capture every individual's entire care journey into adulthood and then follow them beyond to identify mortality after leaving care. So it was primary care and GP data linked to deaths data, which was followed up until June of this year. So within the cohort, we had just over 200,000 young people born or resident in Northern Ireland between 1995 and 2003. That made them aged approximately 18 to 26 years in 2021. Of this cohort, 1 in 5 were known to social services. I think this was our first sort of top headline result, was that it's such a high proportion. Now, known to social services includes children that are both identified as a child in need and then those that are deemed not in need. This is what's quite unique about this study, is that it allows us to not only look at children in care, but those that are identified as a child in need by social services and remain in their own home under care orders with social work assistance, and also those who are referred to social services but deemed not in need and just returned home again without any social services interventions. But what's shocking is that quite a high proportion of young people in Northern Ireland are known to social services. We're talking about 3 or 4 or more in every classroom here. Only 1.5% are identified as a looked after child. So the number of children who are actually looked after, is removed from the home and placed in care, is quite small. But there's quite a large proportion of children that are known to social services that just aren't in care. Over follow-up, we were able to capture just over 1,000 deaths. Now here's a quick table which just is some summary statistics of the cohort structure and a sort of incidence of mortality. I think what's quite unique about this study compared to others is that we have these groups here where we're not only comparing looked after children to the rest of the population, but we can look at children identified as a child in need, that is, they remain in their own home, and children deemed not in need, so don't have any social services interventions. And what we see is that we've got a higher mortality rate amongst young men, amongst individuals living in the most deprived areas, amongst those with a history of being looked after, and amongst the highest was seen amongst those who were known to social services from a very young age. This is those that are become known to social services between the ages of 0 and 3. And the results of our Cox regressions here, exploring risk of death, giving exposure to care before the age of 16 years. We did the sensitivity looking at your full care history up to 18 years, but it gave the similar results. And some children choose to leave care at 16, not 18. And so we can share both with you, but the same associations were evident. And as we can see, children looked after are 9 times more likely to die in young adulthood than children never known to social services. But they're again also much more likely to die of a sudden death when we look in particular at sudden deaths, which are classified as accidents, drug-related deaths, self-harm and homicides, and then also equally higher risk of death by suicide. I think what's interesting here is that the children that are deemed not in need or deemed a child in need sort of have equivalent risk across these groups. They're at a much higher risk of mortality compared to children never known to social services, but there seems to be a sort of stepwise relationship with level of exposure to social services and mortality risk. Looking then within those who are identified as a child in need, so trying to look at, well, of those children who are known to social services and remain in their own home, is there anything in particular about them that are risk factors that we can identify as flags to possibly target interventions? And the answer was not really so far. We've only been able to look at gender and age at which they become known to social services. And as a standard, young men have a much higher mortality rate than young women. And those again that were known to social services at a younger age at a higher risk of mortality than those who became known at a later age. And this is the same for looking at all-cause mortality, sudden death and suicide risk. Again, this only risk factor that we've picked up so far is that if you become known to social services at a younger age, you have a higher risk. And we're beginning to see here that our confidence intervals are sort of straddling 1, and we're beginning to have an issue with statistical power. And that's because as we begin to look at particular risk factors within particular subgroups, we're starting to have trouble with actual numbers. Looking in particular then at children who are looked after to see are there any particular risk factors in looked after children. The same can be seen where males have a much higher risk, but the age at which child becomes known sort of flips here a little bit, where risk of sudden death increases in children in care if they become known to social services and in care over the age of 11, but suicide risk is still prevalent in that younger age group. And there's a bit more work to do here to sort of unpick these associations and try and understand what are real risk factors and what are sort of artifacts of the data. So what does this all mean? First of all, we know that mortality risk increases as interaction with social services increases. Children deemed not in need are a high risk group, and this is potentially an area of missed opportunities for intervention. These children that were once known to social services and returned home deemed not in need still remain high risk throughout their life and young adulthood. Highest risk is for preventable deaths, such as sudden deaths and suicides, and there's a real need to tease apart which aspects of care exposure are associated with risk. And that's what we're doing at the minute, but like I say, we're dealing with much smaller numbers. So the next steps are really to improve the quality of those earlier years of data from 85 to 95 so that we can get a much larger cohort to explore in more detail different care exposures. Now, we work very closely on this project with the Department of Health and with our project partners in Barnardo's. And one of our partners in the Department of Health has quoted as saying, as a department, we regularly receive feedback from children's rights organisations and other stakeholders that the right data doesn't exist and there's further development in this area is needed. So one of the main parts or reasons of our research is to ensure that we are producing the right data that can be used by policymakers in order to inform evidence effectively. I just would like to thank the staff at the Business Services Organisation, where we hold all of our linked anonymised administrative data, and from my colleagues in ADRC. Thank you.